But we're really excited to be here and share with you our most recent study. So I am Tina Hernandez-Boussard. I'm at Stanford University. I'm the Associate Dean of Research for Health Informatics, where I really think about the infrastructure we need in our university to move forward with AI technology and to ensure we have the right infrastructure and workforce to move forward. Thank you for the opportunity.
I'm Madalena. I'm currently a T32 LC Research Fellow and postdoc at the newly endowed Laurie J. Duran Center for Biomedical Ethics at Stanford. So the title no longer stands there. My background is in ethics, societal, and legal implications in the governance of emerging technology. I've had my start in building digital health research platforms at UCSF and evaluating their ethical challenges with informed consent and participant representation. In the past few years, I've had the privilege to work with Dr. Hernandez-Boussard and her team, such as Dr. Huang, to really delve into the ethics and equity implications of health AI technologies deployed locally and across healthcare systems. So very excited to share some of our work here today.
Hi, I'm Yanmi Huang, and I'm a postdoctoral scholar at Stanford Medicine in the Division of Computational Medicine, working with Dr. Tina Hendricks-Boussard. My background is in biomedical informatics, and my research focus on health equity and also responsible AI in clinical settings. I work across three levels: individual patient heterogeneity, vulnerable population disparities, and also health systems patterns of AI adoption. And today I'll be presenting of the Nature Health paper on the landscape of AI implementation across U.S. hospitals, which is on the system level piece of that work.
Awesome. Tina, do you want to start us off?
Oh, okay. Sure. So this is some work that we have started that really started with some funding from the Scown Foundation to really think about the vulnerable populations and how AI is being implemented across different populations. We were so fortunate to work with the team at the Scown Foundation, and then of course we had several members at Stanford University helping us build this resource. And so it really helped us to understand the underlying needs across healthcare settings for how we really move forward with AI implementation. And you'll hear today from both Doctors Ng and Huang, how this has just been such an exciting research study. We learned so much. And so without further ado, I will pass it over to Madalena, and she can take us off and get us started on the study information.
Thank you, Tina. Yes, exactly. So the research was made possible by a grant from the SCAN Foundation, and our study team is small but mighty. So we were really able to surface really interesting findings within the span of a year. And also thanks to the contributions of Michelle, Malvika, and David as well, who couldn't be here today. Um, so a bit of background to set the stage for the main course. So our study goal was to identify biases in healthcare algorithms that target or are deployed in community-based care settings to ensure equitable care for marginalized older adults. And the focus was California. So AI, we know that health AI holds great promise to address the demands of a shrinking healthcare workforce and growing aging population of Americans aged 65 years and older, as well as rising healthcare costs. These pressures are even more heightened in community-based care settings, such as the California Safety Net, hospitals, and FQHCs. While these healthcare settings stand to benefit the most from AI, they are also the most vulnerable to AI biases and algorithm deterioration that may cause harm to communities. And we know that algorithm biases arises in many ways. The focus has always been on the model, but systemic and human biases present with the AI are also important to understand and pinpoint for mitigation. Healthcare organizations on a systems level also have their own systemic and human biases that can greatly affect decision making and the trajectory of AI deployments. Therefore, there's a need to really uncover what healthcare algorithms are already deployed in order to understand the decision pathways that led to their selection or the care of older adult populations. There are hopes that by understanding this, it can lead to improved ethical institutional practices and deployment norms. So in our project plan, we aimed to do three things. First was to create an AI inventory of healthcare algorithms used in community-based care settings, paired with a summative analysis of their available documentation. Two, understand the organizational decision-making processes behind selecting and prioritizing healthcare algorithms, and synthesize that information into a decision-making checklist for community-based care settings to potentially use. And then finally, develop a geospatial map that integrates hospital AI ML adoption status with clinical infrastructure and socio-environmental data. This way we would know what has been deployed already, the decisions behind that, and then expand our understanding to unseen socio-environmental gaps relative to a local hospital context. So for the AI inventory, we carried out a literature review to identify health AI deployed in California community-based care settings and self-reported information from healthcare leaders. For our health AI inventory, it consisted of 30 health AI tools after excluding homegrown tools with limited documentation information. So our AI inventory with the 30 health AI tools, 13 had direct clinical impact. So focus on patient diagnosis and disease prediction, with 8 of those having received FDA clearance. The 17 tools with indirect clinical impact were primarily health systems management or clinical operations tools that serve to streamline healthcare processes or reduce provider burdens, such as ambient AI for clinical documentation. And then notably, the majority of health AI tools in our AI inventory were deployed in community-based care settings affiliated with large academic medical centers. And also Epic and EHR system had the most tools represented. So following that, we wanted to develop model cards for each of the health AI tools with clinical impact. We consulted the state-of-the-art model cards of the moment from Google, Hugging Face, and Chai, and we decided to highlight the metrics that were required by Chai based on consensus from experts. So we looked into publicly available documentation, such as publications and FDA clearance documents to identify these metrics. And Table 1 shows the aggregate information. So for the 13 health AI tools, we found that only one tool had a publicized official model card completed by developers. The lack of comprehensive and readily available information for many of the tools prohibited abstraction of key model card metrics. And while it was encouraging that all clinical AI tools publish performance metrics, other metrics could benefit from more focus and transparency. So from the Chai model cards, they were looking at 3 different types of metrics: usefulness, usability, and efficacy, fairness and equity, and then safety and reliability metrics. So 100% had the performance metrics of the model in risk and classification prediction. A majority of the model developers measured safety and reliability metrics, such as predictive accuracy and time to notification, but only slightly half measured fairness and equity metrics, such as equal opportunity and predictive parity. So finally, only 6 out of the 13 explicitly mention evaluation or validation of the model on older adult populations. So some key takeaways from this part of the project was that the goal of the health AI inventory with model cards was to facilitate knowledge sharing, access to vetted tools, and age-related bias assessments across diverse community-based care settings. However, we found 3 key insights. The presence of organizational disparity between which community-based care settings have successfully deployed health AI. There exists a disparity, so this reinforces a digital divide in AI access. And so those who are tied to academic medical centers are further along with adoption and implementation. And then community-based care settings affinity towards deploying health AI tools that serve health systems management or clinical operations rather than diagnosis and prediction suggest underlying priorities. Perhaps there is immense value and importance of these tools, those health systems management or clinical operations tools, for improving the ecosystem of care, which can eventually translate to better patient care. And then finally, a model information vacuum hinders the comprehensive completion of model cards and reveals systemic omissions in fairness and safety reporting. This may risk harms to older adults and prevent informed decision-making on what health AI tools to deploy in these settings. So therefore, this project highlights urgent needs for transparency regulations, equitable deployment, and group-specific model validation. Moving to project 2 on understanding organizational decision making with health AI implementation, the rationale is that addressing algorithmic bias for older adults is urgent, and understanding where to intervene in safety nets health AI decision making processes can contribute to bias mitigation and improving equity. So understanding where to intervene during that decision-making pathway can really redirect the selection and deployment of equitable health AI for marginalized older adults. So for this project, we used a qualitative approach where we conducted semi-structured interviews with various healthcare leaders from the California community-based care settings. So we aim to have representation across all California regions, not just focusing on Northern or Southern California. And almost all of the healthcare settings were either in the planning, under development, or active use stages of health AI use. So there were a lot of findings, but I parsed out some themes that are most relevant for the next stage of this talk. So some context and quotes to kind of keep in mind. So from the interviews, we found a facilitator. Electronic health record systems are a core infrastructure for scaling AI. A quote that was particularly salient from a healthcare leader. There's two levels where AI comes from. One is platforms, like Epic is an enterprise platform that produces a lot of individual AI things. Those costs are really just bundled into what we pay Epic. And then there is the application level or individual applications of AI tools. And then within that, there's those that we develop internally. And our cost to that is not insignificant because it's man hours essentially. It takes hours and hours to build the solutions and then to maintain them. A barrier is that there remains unclear clinical impact of health AI tools. A lot of organizations are going to say things like cost is a barrier, but I think that's a little bit garbage. There's always a lot of investment occurring in IT tools and other things. A lot of those IT tools that you're already invested in are now adding AI. I think that the real barriers are lack of evidence of outcomes. A facilitator is that the presence of a centralized AI governance process that incorporates the local context really helps in the decision-making process. So we have a standardized intake process that we do for all AI solutions. If the tool is in scope, then we have a graded program where we typically will do a consult with a member of the AI oversight committee. We go through the consult with the requester to better understand the potential impact, the potential risks, and whether there's sufficient concern for algorithmic bias that we need to explore further, and then collect the sum total weight of evidence. Decisions have always been worked out at the AI Oversight Committee level, and we've had very little declination. We've had some decommissioning that has occurred, but in those cases, the jury of peers is really well respected. It's a pretty tough sell to try to go to the executive committee and say, I think that this respected committee of clinical and scientific experts was wrong. So this qualitative study narrowed focus to California safety net leaders' perspectives on health AI implementation and the extent to which older adults are prioritized in decisions. So we found that organizational leaders in community-based care settings are juggling competing priorities. So health AI really requires both due diligence and a clear case that demonstrates how it addresses organizational needs to stand out among those many competing priorities. And then health AI implementation is not selected or prioritized for older adults. Our research shows that older adults and age-related bias mitigation are not prioritized for health AI implementation at community-based healthcare settings at the moment. And then our decision-making checklist. Grounded on insights from those healthcare leaders, we developed a practice-oriented checklist for safety nets to assess their readiness to implement health AI tools, hopefully returning some value back to our interviewees and stakeholders. And then moving safety nets towards sustainable and equitable AI innovation for older adults really requires balancing priorities and trade-offs across multiple contexts. So with that, those are the first two projects that will set the stage before we move to Yeonmi. I just also want to quickly thank members of the HAIP network for their generous time and help in facilitating our last two projects as well. So with that, I'll turn it over to Yeonmi.
Madalena just earlier in the presentation introduced that our project 3 was actually to develop the geospatial map. And while we were creating the map and also hearing from Madalena's interview stories, we were motivated to actually zoom out and quantitatively map out what AI adoption actually looks like across all US hospitals to provide more data-driven evidence that can demonstrate the disparity in AI adoption. Next slide, please. So AI adoption in hospitals is accelerating quickly. They're being deployed to support clinical decisions and streamline operation. But this growth and the adoption is not really happening evenly. In high-resource hospitals, the one with large IT teams, strong infrastructure, and existing data systems, they are far more likely to adopt and evaluate AI. Meanwhile, rural hospitals and safety net institutions are being really left behind. And this is really not a neutral gap, and these are the same communities that already face worse health outcomes. So if AI is keep concentrating where resources already are, it is not going to reduce the health disparity, but it's going to make them worse. Can you move to the next slide? So we organize our study around 4 questions. First, where is AI being implemented geographically? We characterize the spatial distribution of AI implementation. Second, who is being left behind? We examine alignment between the community healthcare need and AI adoption. Third, what drives the AI adoption? We identified hospitals and community level factors associated with AI implementation. And fourth, does AI adoption associate with better quality outcomes? We explored association between AI adoption and hospital quality trajectories. These questions move from describing the landscape and to understand what drives it and to ask whether any of it is actually matter for the patients. For data, we use AHA survey mainly, especially IT supplement from 2023 to 2024. We use annual survey to collect hospital information, and we covered we covered 3,560 hospital, which is about 58% of all AHA registered hospitals. We link this to community level indicators such as area deprivation index, social vulnerability index, HRSA shortage designation. We also link to US Census data. And then we also link to CMS quality metrics spanning from 2022 to 2025. Methodologically, we use spatial clustering with Moran's Eye, DB-scan, and hospital analysis, random forest, which for feature importance, geographical weighted regression to capture regional variation, and linear mixed effect model for quality trends. Each method was chosen to help answer a specific question, not just where AI is clustered, but why and what that means. Here is where we stand nationally. So about 49% of hospitals in our sample have adopted AI-based predictive model. Another 16% use non-AI predictive models, and roughly 29% report no predictive models at all. And when you break it down by census division, we can also see some regional variation. Some census division are well above 50% of adoptions, and others are well below. This map shows that AI adoption is not randomly spread across the countries. Moran's Eyes is statistically significant, which means that hospitals with high AI adoptions tend to cluster near each other. We also found 434 distinct clusters covering over 90% of hospital in our sample. You can see that adoption is concentrated in coastal metros, while inland and rural areas are lag behind. And now we want to acknowledge that part of this clustering just reflects where hospitals are, and hospitals themselves are more concentrated in studies. But even accounting for that, the spatial patterns of adoption is pretty striking and meaningful. So given that what we observe significant spatial clustering, we wanted to take this one step further and ask, are these specific areas of statistically significant high or low adoption? So we conducted hotspot analysis, and at the hospital level, we identified 658 hotspots and 570 cold spots. And we then aggregated these up to the hospital service area level for the visualization purpose. And what is useful about this is that hotspots and cold spots are not just areas with high or low adoption. They're areas where the pattern is just statistically reinforcing itself spatially, and that makes them a concrete evidence-based geographic targets. For policymakers and health systems leaders, these are the place where intervention and investment could be more strategically focused. This is one of the most important slide in the talk. We calculate the implementation ratio, which compares AI adoption in high needs versus low need area. An implementation ratio below 1.0 means high needs area are adopting less. For healthcare access indicator, we consistently see low implementation ratio, and even for socioeconomic indicators such as area deprivation index shows a ratio below 1.0. And we do find this patterns pretty concerning, as one of the AI stated potential is to mitigate the health equity gaps. But what we are really seeing is suggests that we risk exacerbating them instead. So we looked at this more closely in a separate NEJM AI perspective, which brings to the next slide. So more than 50 years ago, Julian Tudor-Hart proposed the inverse care law, that availability of good medical care varies inversely with the need for it. We published a perspective in NEJM AI earlier this year, arguing that AI and healthcare risk repeating this exact pattern. This figures tells the story. So on the left, healthcare need increase as you move from metro to rural, higher mortality and higher chronic disease burden, and also higher poverty. On the right, resource decline. So fewer hospitals, fewer physicians, fewer psychiatrists, and in panel F, we do see that all indicators for AI capacity, such as AI adoption and LLM readiness, also decline from metropolitan to rural areas. So where need is greatest, AI capacity is lowest. And this is not inevitable, and we are really on the trajectory making the disparity worse. And addressing this will require deliberate policy action at the infrastructure level, not just at the technology level. So what actually drives the AI adoption? Based on our finding, the top predictor was the core index, which reflects the hospital's interoperability capacity. That hospital can exchange data with other systems and are much more likely to adopt AI. And the second predictor was the friction index, which is the barriers to data exchange. So this was negatively associated. System membership and delivery system structure and best size also rounded out to the top 5. And one thing interesting was that community level factors such as social vulnerability index was also ranked among the top drivers. So this is not just happening inside the hospital, but also community context around it as well. So both institutional and community factors together shape whether hospital adopts AI. And the key implication here is that what predicts adoption is not just clinical need, is infrastructure and capacity. And that means that if we want to close the adoption gap, we cannot just incentivize the AI procurements. We have to invest in the foundational data infrastructure first, and particularly in underserved systems, as we could also observe from Madalina's work. We then ask whether these predictors hold everywhere. We used geographical weighted regression, and answer was mostly no. The one exception was the core index. Interoperability was consistently and positively associated with AI adoption in every region. But for everything else, bedside ownership, Medicaid, percentage, like community indicators, the relationship with adoption varies substantially by region, sometimes flipping direction entirely. The implication for policy is here it for policy is important that one size fits all national strategy will really not work. What drives adoption in one region is not what drives in another, and effective intervention needs to be regionally tailored and built around the local, institutional, and community context, not handed down as uniform mandates. So does AI adoption actually lead to better outcome? We looked at 70 CMS quality metrics across 15 quarterly time points. So we found some favorable trajectories such as pneumonia mortality, hospital-acquired conditions, excess acute care days after discharge, and COVID-19 vaccination rates. But we also observed some less favorable outcomes such as readmission, emergency department wait times, unsafe opioid prescribing rate, and also worse outcome for sepsis cares. Um, these patterns are most one thing we want to point out here was that we have like major limitation for this finding, so that's why we kept it a very exploratory um, analysis here that we couldn't really precisely capture the time of adoptions, and we couldn't really link the specific outcomes to specific AI tools. And AI adoption is not the same as integration, and we didn't have the metric to really capture the integration either. So this finding that like this exploration of analysis was more to highlight that the need to actually have the standardized metric and reporting system to better understand what is the actually the outcome leading of AI adoption to patients and also to the hospital level. So let me bring here together. So AI adoption in the U.S. is spatially clustered, concentrated in metro and coastal area, and the communities with the greatest healthcare needs. Can you go to next? Can you just show the whole thing? Yeah, thank you. The communities with the greatest healthcare needs are adopting the least. And the interoperability is the one that has a consistent predictor across all geographies, which means that data infrastructure, it is really the prerequisite, not optional. And regional context matters really for everything else. So uniform national policy will not really work. And also, we also found that most hospitals are still not evaluating their models for accuracy or bias. So, um, and we really need a better metric to do so. And the bottom line is that we have the baseline of understanding what it is like now. We now know where the gaps are, we know what drives stems, and we know what we need to measure going forward. So the question is that whether the field will act on it and or whether we will repeat the same patterns that have defined health inequity for decades.
And thank you to the HAIP network again for inviting us for this talk. And with that, we will take questions.
Thank you all so much. We can maybe get started with some of the questions in the chat, but feel free, folks, to raise your hand and I can call on you to unmute or to continue to put questions in the chat. The first
Sorry,
one.
sorry, just to note, here's a QR code if you want to see all the resources from all the three projects and the code for the geospatial map as well and other different resources. Okay, sorry about that.
No, no problem. So the
Yeah,
first question,
yeah, go ahead, sorry.
the first question that I'm seeing in the chat is in terms of what drives predictive AI adoption, does this ultimately showcase that past historical gaps, such as technology and infrastructure, are reinforcing factors or leading to the same gap in AI adoption? And they indicated that they're curious if AI fluency or capacity was mentioned or part of the picture.
Yeah, Madeline, do you want to tackle that one first from your qualitative work? I think gave you a lot of insights, and then Johnny, maybe you can kind of talk about it in terms of what we found in regard to evidence.
Sorry, Sierra, are we looking at Bogdan's question?
Yes.
The last question, right?
Yes. The most recent one.
Hmm.
Yeah.
AI fluency or capacity, if it was mentioned. Bogdan, do you mind clarifying your question?
Can. So ultimately, as I was looking at that graph, it seemed like the most predictive factors of whether a health system would adopt AI had to do with interoperability and infrastructure. And so it kind of dawned on me then, is this it's kind of the same story to a certain degree. It's, institutions that don't have the infrastructure to support more advanced features. AI just happens to be one of them. I'm curious if that was the finding. And then similarly on the fluency side, I'm curious whether through your interviews or the discussions that you've had with health system leaders, if the capacity of their staff or even of their own kind of executive leadership, did that come into play in terms of how AI may be used more effectively or perhaps less effectively?
Yeah, Yami, do you want to address the first question? And I think I have some quotes that I'm trying to look up for the second question.
Yeah, I think it does really show that past and historical gap is being like reinforced again here. And we also tried to distinguish it, but we really couldn't because those are all intricately linked to it. And also there is not enough like variable that we can actually come like address that confounding. So it is really reinforcing that past historical gap.
Yeah, and then in terms of literacy capacity, that definitely came up in our interviews as well. Trying to find the specific quote that we had. Yeah, there's definitely a gap in specialized AI expertise that the healthcare leaders have said that they need in order to be facilitate AI implementation. Um, So the challenge, I could read it. The challenge comes when you don't have the data science expertise, because there's a ton of nuance in this space in evaluating these models. A lot of triangulating on what the real questions are, what the real concerns are. We just don't have that like sort of wealth of human resources that have the appropriate expertise and experience in the space. So it makes it very, very challenging to generalize AI oversight outside of settings in which those resources exist. So that is definitely a gap that's seen in community-based care settings, at least in California. Hopefully that helps address the question.
Yeah, and I'll just say, just to reiterate that, right, the hospitals that already have the strong data infrastructure and analytics and governance structures, et cetera, are really in a better position to implement, evaluate, and really monitor these systems. So, there's, of course, they've got a step ahead of some of the other systems. So, it is really suggesting that like successful and equitable implementation really may require more than simply just making models available to people, but really enforces our need to require like investment in implementation ecosystems and workforce development and government's infrastructure. Otherwise, there's a real possibility that we're just, seeing the people with the most technology, the most resources are the ones that are going to be using the technology the most.
Thank you all. The next question I'm seeing is from Alice Liu. She said, read the earlier slides. One of the earlier slides is prioritizing AI for health system management and clinical operations more about prioritizing lower costs and burden of operations or being more risk averse to using AI for clinical decision making?
Yeah, I could take that one. I think it's definitely about both. Exactly what you said, lowering costs and burden of operations, and also being more risk averse to using AI for clinical decision making. In our recommendation, from the analysis, we recommend that potentially uh, community-based care settings could probably makes more sense to invest in these tools since they have a shared understanding about like how they work out in practice, and then hold off on the um, clinical AI tools until there's better safety, fairness metrics, information about those tools, as well as improve transparency from developers as well on how they were tested and evaluated. So there's difference between like lower risk tools and higher risk tools. So I think that's what the community-based care settings are, how it's playing a role in prioritizing and selecting tools for implementation.
Yeah, and I will add that, these two are really deeply interconnected, right? Operational AI systems still have a significant downstream effect on scheduling, staffing, documentation, and patient messaging, which can indirectly affect like access to care, right? So, for example, we have AI systems that are like doing scheduling. So they're really starting to determine who gets those appointments and who do not. If you look at some of the prediction algorithms that predict no-show appointments, for example, right, they might deprioritize a patients who have barriers to transportation or something like that. So we're already seeing, even though they're separate, they're deeply interconnected. So it's just, important to understand that.
Alice, any follow-up questions?
No, thank you for answering my question because yes, this you make good points and the rationale makes sense and then also recognizing the downstream effects could have the, let's say, the upstream or side stream effect in terms of actual patient care. So yeah, it is very hard to tease apart. Um, and I know you had probably quite a few challenges in trying to do that in your study. So thank you.
And then I'm also seeing Bogdan's earlier question, remodel cards. Are there proportions based on publicly available model card information, or does that include any and all performance metrics available either publicly or privately?
Yeah, so for that question, we excluded homegrown tools because there was limited information, documentation from those tools because maybe they're being developed by research teams like in-house. So it also limits the generalizability of these tools to other settings. So we excluded those, and then we mainly relied on publicly available information. And from our analysis, a content analysis, it showed that um, they were not all they were not all available, right, with the fairness and safety metrics. But performance metrics were all there. But at first, we had to exclude those homegrown ones first that didn't have the documentation.
Bogdan, any follow-up questions?
Nope, that was it. Thank you so much for taking my questions.
Thank you.
Okay, and then the next question I'm seeing is from, I'm not sure if I'm going to pronounce your name correctly, but Nirmal Ravi. Since most rural or urban practices don't have the ability to evaluate AI tools, we'd love your thoughts on how that can be addressed by organizations like CHAI and HAIP to independently evaluate or at least provide frameworks for these tools.
Well, I'll go ahead and start that. I think it's a really great question, and it's a real gap in where we're going, where we are right now. The problem is that technology is just moving so fast that we just can't keep up with the regulation and governance of these tools. And so therefore, even if we start thinking about how we might help lower resourced hospitals or communities in really bringing their technology, their workforce up to speed, we often get outpaced by technology. So we could still be working on, for example, static machine learning algorithms and how we get those into practice. And now we're looking at, large language models or chatbots, et cetera. And so there's been a lot of look at, what are the benchmarks that we need to move these into practice, and what are the standards, and who's developing these. I think that there is a great need to really think about how we build the infrastructure. And I think that was sort of the recommendation from Yeonmi's paper and this work, is that it's not just about building better models, and it's not just about getting the models to these other community hospitals. It's about really building the infrastructure and the resources and the workforce capacity that needs to maintain them. And because it's not just about implementing them, it's about implementing them and monitoring them and ensuring that they are really being not causing any type of harm or unintended consequences. So maybe Madeline or Yami, you want to add to that?
Yeah, I want to quickly add to that too. I think this goes back to one of the findings that, facilitators centralized AI governance process that incorporates the local context. We recommend that, like AMCs, academic medical centers nearby, there are ones that are nearby rural or urban practices, have the resources, and potentially they are farther ahead with AI governance, and possibly partner with them to kind of have synergy and utilize resources that way to help evaluate AI tools. So learn from each other. But the local context is very important, because community-based care settings are driven by local needs and values, and those also need to be considered in AI governance. So to have that partnership and that two-way dialogue is very important, and not to rely on more national organizations, I would think, because then you may lose that local context. That's really important in evaluating health AI tools.
Yeah, and one of the purpose of creating that geospatial map was for the hospital level, they can see in the neighboring hospital, like what do they have a similar characteristics, and do they have like a similar infrastructure, then they can actually ask. And if if the neighboring hospital is doing better than us, then what they can actually go reach out for like strategic relationships. So that's one of the purpose why we were creating that geospatial map.
And I think it's been so interesting for me. This is a tangent from the questions, but so much of what you all have shared aligns with what we learned in our Practice Network program. And so that's been really interesting to see that you all observe similar trends at more of a national level as well. One of the sites we worked with, the Community University Healthcare Center in Minnesota, has a partnership with the University of Minnesota, and we saw that made a huge difference in their ability to implement AI tools, getting support from UMN. So just very interesting to see those parallels and alignment. The last question I'm seeing in the chat is from Mary, and she's saying, what was the definition of AI infrastructure? Did you include AI governance, or how are you thinking about the term AI infrastructure and what that encompasses?
Yeah, I think I'll pass that to Yeon-mi.
Was this part of my presentation? Oh, okay. Um, do you mind clarifying which part it was?
I may have missed it because I came in the middle, and I was just looking for a clarification of when it's been referenced about AI infrastructure, and how that may be influencing AI adoption in certain areas. I was wondering what definition of AI infrastructure you were using, and if
Okay.
that included governance of AI within that term.
So AI governance was not specifically included, honestly. In AI infrastructure, we were more focusing on the hospital level resource capacity, including interoperability, but also in general, like the size of the hospitals. And in terms of governance, we do include if the hospital was part of the Joint Commission, but it's not really AI governance exactly. So we do not really include the AI governance in this when I describe as an AI infrastructure.
Thanks for
But
clarifying.
yeah, Yami, a quick question for that. For the AHA annuals, the IT supplement, did they not also collect information about the presence of like equity initiatives inside the hospital that was accounted for in the analysis?
Well, and no, not for this part. That was not really related to AI, so I didn't really
Mhm.
include it as a part of the analysis.
Okay, gotcha.
And a few more get added to the chat. If anyone wants to come off mute and ask their question, feel free to do that as well. But the next question I'm seeing is from Alice. And she said, regarding recognizing the needs and perspectives of older adults in AI for health, are there any notable examples of organizations working on this?
Well, I will start and say, our work was funded by the SCAN Foundation, and that is really a priority of their work is understanding the health and the well-being of older adults. And so I know they still are very focused and very interested in that topic. We also, there's also the National Institute of Aging that's really prioritizing AI for elders and elder care. So I think there's a lot of, certainly as our population is aging and we're seeing more and more burden from more complex comorbid patients. There's been a lot of interest here. And I don't know, Madalena, Yamni, do you want to add anything to that? I'm not sure if I answered the question or you're asking, but I think there's a lot of interest.
Yeah, I agree. I think the SCAN Foundation is one of the main people who are very focused on this.
Okay. The next question I'm seeing in the chat is from Nicholson Price, and he wanted to know, did interviewees talk at all about regulation or liability as part of their considerations? And he's curious from his perspective as a law professor.
Yeah, yeah, that's definitely in our decision-making checklist, considering like the surface, the liabilities and risks. So I think I have a quote that might resonate. This one person said, I declined a vendor. They had very unusual language about HIPAA protections, and effectively it would have put the onus on the organization, which is very uncommon. Each revision still didn't satisfy. And I was like, all right, I'm sorry, we can't go forward. And of course, they changed it. Like, I won't play with a vendor that does that. You already were way too suspicious about HIPAA to begin with. So that kind of surfaced in our interviews. So hopefully yeah, that's definitely something that to be on the lookout in terms of, yeah, making sure that there's trust between vendors and organizations in order to decrease liability.
And then I'm seeing a question from Ashley. I believe this is a follow-up to an earlier question about older adults and kind of services available to them. She's curious about AI literacy for patients, and particularly the at-risk elderly populations, and whether that was explored as an influence on AI adoption.
AI literacy for patients. I don't think that surfaced in the interviews. It was more about AI literacy amongst the staff and the organization. And by continuous education and socialization of health AI and the ethical implications, like that helped um, upskill the whole entire organization to understand and know how to assess AI, and potentially that could be a facilitator for AI adoption.
I think we have time for one last question. So I'm gonna go to Zach because I don't think we've heard from him yet. But as you said, the AI field is changing fast and requires intensive work to implement and monitor. Is it your position that all hospitals should be trying to implement more AI, or as of today, do some low-resource hospitals stand to hurt themselves by implementing tech they can't maintain? Tricky question.
That's a great question to end on. I'll go ahead and take a stab, and then maybe this is where we can all end and just kind of give our thoughts and opinions on this. I think that it's really hard for hospitals right now to not be considering the implementation of AI. Certainly on the operational side, we're seeing benefits in regards to staffing and appointments, et cetera, et cetera. But I think patients are also asking for it, right? We see here that patients are coming in with questions from their chatbot or their MedMD or different places where they're getting it. And so I think there has to be a balance. I think it would be really hard for a hospital not to have something implemented. But again, as we were mentioning, it's going to be about partnerships. And I think it's going to be about building partnerships and really strategic partnerships that can leverage, different aspects. I will just mention we were doing some work with Alaska Native, the tribal communities up in Alaska on how we can partner with them to really help their workforce and in identifying which questions, what are their most urgent questions that AI might be able to address, and trying to understand, there's some questions that AI can't help them with. But if there are questions that AI can help them address, how do we think about working together in a partnership with the community to make that happen and move that forward. So I think we're going to see a lot of movement in this space, and I think the strategic partnership's really going to be our guiding light.
And just add to that, I think in our interviews, some of the leaders mentioned that there's a perception that if you're not implementing AI or at least trying to, then potentially patients might perceive it as providing substandard care. So that is something to also think about.
I think they did describe most of it. It's really difficult to come up with like a solution, right? So I think one of the practical solution or way will be like having the strategic partnership for sure. But
For sure.
yeah, beyond that, it's like difficult to say. Yeah.
Okay, well, thank you all so much. We really appreciate you making the time to come share your findings with us. It was really great to be able to hear from you directly, and to be able to open this up to questions. And thanks to our audience for submitting some fantastic questions. We hope to see you at a future event. And if you have a few minutes, please scan the QR code on your screen. We'd love for you to take the survey about our session today and share any future topics that you're interested in learning about. Thank you so much.